Hi, my name is Christine Sufchek. I'm a third-year pediatrics resident, and I'm excited to be able to share the results of my research with you all today. This is a project entitled High Value Care, Analyzing Blood Culture and Wound Culture in Pediatric Orbital Cellulitis. This is a project I completed with my colleagues, Dr. Gargi Mukherjee, Dr. Nicole Hames, and Dr. Patricia Lantis. So orbital cellulitis is a serious bacterial infection that we all see on inpatient pediatric services. And what we had noticed as we were taking care of these patients was that they often receive blood culture on admission, and if they go to surgery, they often receive wound cultures as well. And so our clinical questions were, what organisms most often cause orbital cellulitis, and can we gain additional insight into those as we look at the results of those blood cultures and those wound cultures? Also, we wanted to know, do the intraoperative wound cultures, which are often pre-treated with empiric IV therapy, are they useful in the management of pediatric orbital cellulitis? And similarly, are the blood cultures useful in the management of pediatric orbital cellulitis? And what I mean by that is, do we take the results of our wound cultures and the results of our blood cultures and use that information that we've gained to make meaningful clinical change? And so that's kind of what we set out to find. In order to do this, we looked at a cohort of patients that were admitted to two children's hospitals, Eggleston and Scottish Rite, between August 2012 and October 2019. This is a retrospective study, and we included patients who had orbital cellulitis who were 18 years of age or younger, and we excluded kids who went to the PICU, kids who had intracranial extension, kids who had trauma or postoperative reasons to have orbital cellulitis, as well as anyone who was immunocompromised or who had underlying orbital disease. So that left us with a patient population of 301. And we can kind of see in figure 1 that the patients who had blood culture, there was about 2/3, 1/3 split. So about 2/3 of our patients had a blood culture drawn. And of that 194, 8 were positive and 196 were negative. As far as wound cultures, it was kind of the opposite, interestingly. We had about 1/3 of our patients who went to surgery, and then most of the patients who went to surgery went on to have wound cultures drawn and sent, or swabbed and sent. And then the other 2/3 of patients did not go to surgery and thus did not have a wound culture sent. Once the wound cultures were sent, about 85% of them came back positive, and the remaining 15% came back negative. Keep in mind that number is despite empiric antibiotic therapy. So actually 100% of the patients who went to the OR and had an intraoperative wound culture sent were treated empirically with IV therapy prior to that wound culture being sent. Now, that might have been a matter of a couple of hours, but we had patients from a couple of hours all the way up to 6 days of empiric antibiotic treatment prior to going to the OR to have those wound cultures sent. Moving on to table 1, we can look at the pathogens that we identified from those wound cultures. You can see these listed in order of frequency. And in figure 2, we have them listed a little bit more clearly. These were the most common bacteria that we found. You can see that strep anginosus was by far and away the most common cause or the most commonly found bacteria in the wound cultures, followed by strep pyogenes, MSSA, strep pneumo, moraxella, and MRSA. One thing I want to point out that I think was pretty interesting was that we always think about MRSA as being this big bad bug, which it is, but it's usually at the forefront of our minds when we have patients who we admit with orbital cellulitis. And so I thought it was kind of interesting that it really only was found and isolated in about 7% of the wound cultures that resulted positive. Now, to determine if our wound cultures resulted in a meaningful clinical change for our patients, we looked at their empiric and discharge antibiotics. The most common empiric therapies were ceftriaxone and clindamycin combination therapies. And then we looked at the discharge antibiotics in patients who had a positive wound culture and compared those to patients who did not have a wound culture. So you can see in figure 3 that patients who had a positive wound culture were more often sent home on monotherapy. You can see Augmentin, about a little over 40% of patients were sent home on Augmentin. Clindamycin alone, about 10%, compared to patients who did not have a wound culture. Only close to 20% were sent home with Augmentin, and then maybe between 15 and 20% on clindamycin. So overall, less of them were sent home on monotherapy, and their most common discharge regimen was a combination of Augmentin and clindamycin. When we were doing this chart review, we made note of every time a patient was narrowed specifically for the positive wound culture and those sensitivities. And we found that actually the antibiotics were changed for 67% of patients who had a positive wound culture, and were narrowed down to monotherapy for 86% of those patients. That's pretty impressive numbers, in my opinion. Moving on to blood culture, like I said, we had 194 blood cultures that were drawn and 8 were positive, so that makes about 4% positive. And the positive blood cultures are listed here. So we have 4 MRSA, 2 group A strep, and 2 strep anginosus. In contrast to wound culture, only 1 of the positive blood cultures resulted in a change of antibiotics. And I think that is probably due to 2 reasons. 1, because not very many blood cultures came back positive. And 2, because what we're empirically treating for when we admit a patient is MRSA, as well as the most common bugs. So like strep anginosus, group A strep, MSSA, you wouldn't, if you had a blood culture come back with one of those organisms, you wouldn't necessarily need to change your management. So overall, we found that the blood cultures were less useful in the clinical management of orbital cellulitis in pediatrics. So moving on to our conclusions, what did we learn from this study? We learned that strep anginosus is the most common pathogen found in wound cultures in our patient population, and that though MRSA was not very common, our empiric antibiotics mostly still covered for it, as our most common empiric antibiotic regimen was clindamycin combined with ceftriaxone. Wound cultures did impact management even after 100% of the patients who got wound cultures done had empirically been treated with antibiotics. So we concluded that wound cultures were clinically useful and a good idea to send, and did impact the outcome for those patients. In contrast, blood cultures were not shown to be useful in the management of orbital cellulitis, since of the 400, only 4% came back positive, and of those positives, only 1 resulted in a clinical change in management for those patients. Again, my name is Christine Sufchuk, and thank you for listening.